but deploy solutions that are accessible and can be scaled so that we can actually have societal impact. That's something that the Institute is working on with different projects with. And so today we have actually a speaker who completely embodies this. And he, so Dr. Sid, we are very welcome to you, Dr. Siddhartha Sikdar. I have known Siddhartha maybe through the biomedical engineering world, even though he's an electrical engineering degree holder from University of Washington, but you will see how he has worked himself into everything from a public health person to a biomedical engineer to a sociologist, all of that. And so I've known of his work for a long time, and personally I'm thrilled that you were able to take time to come here. He's a distinguished university professor at George Mason University. He directs the Center for Advancing System Science and in engineering innovation. So you see the words that we are talking about already, right? He has a very interdisciplinary research group. He has had this fantastic NSF-funded transdisciplinary graduate training program that has actually brought a lot of the stuff that we talk about to the next generation and training of the next generation of people. Many accolades, but I will tell you that to me, the most important accolade that I can give you is that his work is making societal impact, and beyond everything else. So please welcome Dr. Siddhartha Sikdar to the talk, and I will let him talk more about biomedical.
Thank you so much for that very kind introduction. It's really a huge pleasure to be here and see this wonderful building that you guys have, the vision that Ranu was talking about, that really strongly resonates with a lot of the things that we have been trying to do at George Mason for a few years now. I'm going to start by talking a little bit about our center and what we're trying to do in our center, and then we'll talk a little bit about some of one of the research projects that I've been working on with a little bit more detail. So I just wanted to start by saying that I'm a co-founder of MyKinetics LLC. I'll talk a little bit about some of the technology that we are trying to commercialize through this, but that's what I'm going to do. So many of you may or may not know about George Mason University, so I thought I'd start a very quick introduction. We are the largest public university in Virginia, even though some of the other peer universities are probably better known, but we are the largest. We are in the DC metro area. We have over 40,000 students, which is about the same size as Arkansas. We really have a very diverse student body. It's one of the most diverse, it is the most diverse in Virginia, but also one of the most diverse nationally. And so a lot of the students that we have are first generation in their families to go to college. We have a lot of students from very diverse economic backgrounds. Many of them are non-traditional students. So my very first grad student was actually much older than me. She came back to do research after having a very successful career. So we have a very somewhat different student body. And that really makes it a very vibrant place to work. So I really enjoy it. I've been there since 2008, so it's been a few years. So I'm going to talk a little bit about our vision for our center, which actually aligns very well with what Rana just articulated. So we talk a lot about system science, and the idea for system science is that we cannot really think about disability and disease as a biomedical problem that needs to be solved. It truly is not. That's been the biomedical model has been the dominant way of addressing disability. For example, in our center, we do a lot of work on various types of disabilities, but that is only a very small piece of the overall puzzle. Individuals live in their environment, live in their communities. They have support networks, policies, not only just healthcare policies, but other policies also affect their health. And so one of the frameworks that we try to use in our research as well as in our training programs is this NIMHD research framework, which talks about these different levels of influence, which is at the individual level, the interpersonal level, the community level, societal level, and also there's different domains of influence. the biological domain, the behavioral domain, and so forth. So really trying to think about whole person health as not only just a biomedical problem, but really an interconnection across these different levels and domains of influence. So how do we work in this domain? How do we do research in this domain? It's extremely complicated. I'll give you an example of chronic pain. This is a project that we've been working on for many years. And chronic pain, of course, there is a biological basis for chronic pain, but your mental health and psychosocial factors strongly influence chronic pain. The environment you live in influences chronic pain. Events that are going on in your lives, the stress of external factors strongly contribute to chronic pain. This is a dynamic experience that changes day to day. So typical research projects where we measure something at one time point and try to see how an intervention might lead to a change in that measure is really not a good way of looking at something as complex as chronic pain. We really need to think of other ways. So we have been trying to develop novel ways of actually using computational methods to try to integrate data across these different domains and levels of influence, and also really working with our community partners to try to better understand what the lived experience of chronic pain is. Looking at how the broader ecosystem affects an individual's health and well-being. So that's sort of an overall framework. So at the center, our mission is to advance medical technologies into the real world through human-centered design and community-engaged design. So I'm going to talk a little bit about those and how we are trying to do that later on. And really centering the lived experience of real individuals. And this is something that we talk about a lot in our training program, is really trying to understand, trying to break down the barriers between an academic researcher who may or may not be the expert and individuals and community partners who actually have more knowledge about these problems. And so they should be not only thought of as equal partners in the research process, but sometimes even more. We should defer to their expertise in many ways. And that is very difficult for academics to get over that hump. And so a lot of what we try to do is this community-based participatory research, where we're really trying to center the lived experience and the knowledge in the communities to try to inform our research questions. So the areas of interest for us are mobility impairment. So we do a lot of work on assistive technologies for individuals with limb loss, stroke, spinal cord injuries, and so forth. We have a long-running program on chronic pain that we'll talk briefly about. And then we also have a lot of expertise in mental health and substance use disorders in our faculty. So we have about 21 core faculty in our center. They come from engineering, data science, social science, policy, healthcare, all the different domains that Ron mentioned that are critical. So the way we have organized, we recently went through a revamp of our center. So now we have these 4 cores in our center. So there's the science and engineering resource core, where we have a lot of our research labs, fabrication and prototyping facilities, nothing fancy like you guys have, but we're trying to build up capacity. We have a preclinical imaging facility, a lot of human imaging. We are doing a lot of instrumentation development for wearable biosensors, so we'll talk a little bit more about that. And of course, we have a data science and AI core expertise there as well. And then one of the things that we really emphasize is this clinical research and translation. So we do a lot of human subject studies. We have an MRI facility. We have a lot of ultrasound imaging going on in my lab. We do a lot of human movement analysis, so biomechanics, motion capture, sometimes markerless motion capture, which is also becoming more and more common. So trying to look at both the traditional motion capture and novel technologies. We are doing simultaneous sensing at multiple levels while we're doing motion capture. So really trying to understand a complexity of human movement from multiple perspectives. There are faculty who have background in mechanical engineering, so we're doing a lot of robotics. So we're building exoskeletons, assistive technologies, and so forth. And a number of our faculty also have expertise in VR and AR, particularly for behavioral health. So they are trying to, one of the projects is looking at individuals with substance use disorder, trying to expose them to cues to see how they might be able to modulate their cravings based on cues and interventions for that. And the other part that I am personally very excited about this community engagement and outreach core. We have a number of faculty who have expertise in community-based participatory research, and that we really do a lot of work with our community partners. So every year at our retreat, we invite a lot of our community partners to come. There's a lot of bidirectional knowledge transfer at these retreats. So these are examples of some of the community partners in the local Northern Virginia area, and really trying to look at all these different levels of the ecosystem. And the challenge for us is of how to actually operationalize this. So there are many different ways of doing community engaged research. Some of these, the more traditional ways, take very long timescales to actually lead to results. Almost takes many years to build trusting relationships with community partners. And so how do you have a grad student who is also trying to defend their dissertation? How do you get them to do this kind of long engagement? So we are trying to come up with these hybrid approaches where we also have these rapid cycles of human-centered design, borrowing from the traditional CBPR. So coming up with a more hybrid model, which is a little bit more agile, a little bit more faster than pure CBPR approaches. So we are trying to innovate in that space as well, coming up with new approaches. And so one of the things that Rana mentioned, this is something that we are very proud of. This is our NSF-funded training program. It's been going on since 2019. So we are in our last cohort this year. We have 83 students. The graduate students go through the program over the last 6 years. So we have really impacted a lot of students. And what we do is we bring students in from all across the campus. So our current cohort has a student who is an English major, psychology, social work, bioengineering, computer science. So really, truly interdisciplinary, much more than other interdisciplinary programs that I know about in the NSF program. So we bring these students in, and they are forced to work in teams, which already is a big challenge. And how do you get a engineer, a social worker, and an English major to even start talking about research? And that's itself a challenge. And then we tell them to take it one step further and say, you're not going to really work on a research project in this program. You're going to go talk to the community partners and really center your research question based on what the expertise in the community is, what the problems in the community are, and then work on something that will address a small part of the problem. And these problems are, of course, wicked problems. They're not going to get solved in a year. But at least can you make some small improvement? And even if you don't end up solving anything, even if you understand the problem better, that itself is a huge step forward. So I think this has been transformational to many of our students. They have changed their dissertation project based on this 1-year experience. And so in this program, the outcomes that we usually track are, can students define a problem from multiple perspectives, not just what they read in the academic literature? Can you actually incorporate the lived experience of the community into formulating the research question? Can you utilize the design thinking, so iterative human-centered design, to break down these open-ended problems? Can you communicate effectively with community partners? Just that itself is a huge challenge. So imagine putting a computer scientist out into the field to do interviews with individuals who are peer recovery specialists for substance disorder. Just that experience itself can be quite changing in terms of perspectives. And then they try to develop solutions. And this is something that, it's very difficult to innovate in a short period of time when these problems are so complicated. But we are trying to make some progress on this. And really, how do you work productively in these very diverse and multidisciplinary teams in a short period of time? So this is, we've been doing this for a while, and we hope to continue this program in a slightly modified version. So it's already being incorporated into our graduate program. So I'm going to give you one example of more of a research project going on at CASB. This is a project that I've been involved in from the very beginning since my time at Mason, and this is really looking at chronic pain. And chronic pain, as all of you know, is the leading cause of disability worldwide. It is actually very complex. So most chronic pain is unexplained. There's usually not a well-identified cause that you can point to. Sometimes there is, but for the vast majority, it is not clear. Even if there is an underlying cause, for example, knee osteoarthritis is one example where there is some pathology in the knee, but the pain experience is actually not solely driven by the pathology. So even if you treat the knee osteoarthritis, have a knee replacement, many individuals continue to experience chronic pain afterwards. So just addressing the biomedical problem does not necessarily lead to a solution. So we are trying to, again, take a very interdisciplinary approach to this. So our team, we've been working together for many years now. This has imaging folks like myself, neuroscientists, data scientists, physical therapists who treat these folks, physical medicine and rehab, social work faculty. So we're all, and also more importantly, we have this chronic pain community advisory board. And these are patient advocates who serve on this board. We also have community-based practitioners who are part of this board. So they're not academic researchers. These are individuals who are seeing people in the community. And we have had some really eye-opening conversations about the disconnect between academic research and what's actually happening in the pain clinic in the community. And so really the highlights are to try to bring all this together. So we are doing hard science, we're collecting data, we're doing imaging, we're collecting biomarkers, trying to make sense of this, but also really trying to capture the lived experience of chronic pain itself. And so we are using large language models to try to take a patient narrative and really try to come up with a way to map that into, let's say, international classification of function at scale to try to capture an authentic patient narrative. And there's a lot of information in that, but how do we convert that into something that is quantifiable, that we can track over time? So that is something that project is going on. And so I'm going to switch gears a little bit and talk a little bit more about another specific project, and this is related to biomedical ultrasound and rehab. So switching gears, a little bit of a hard left. Okay, so my background is in ultrasound. So I got my PhD at the University of Washington in Seattle, where I had the great fortune to work with many of the pioneers in ultrasound, which a lot of the Doppler ultrasound techniques were developed at the University of Washington. So I got to work with some of the pioneers. So I really had a long-standing interest in ultrasound. As many of you know, ultrasound has become more and more miniaturized, right? So it's no longer these card-based systems in hospitals. Point of care ultrasound is something that's very common now. It's used in a wide variety of settings. And this is really has led to a transformation in how imaging, how accessible imaging is in many different settings. So it's used at the bedside. It's used in austere settings, so in rural places and for global health problems. Ultrasound is often the only imaging modality available. There is even X-ray is not even as widely available as ultrasound nowadays. We work a lot with military populations, and the military is very interested in ultrasound because, again, this is one of the only modalities you can have in the field. It doesn't require electrical outlets. It doesn't require any fixed equipment at all. You can take a smartphone out of your pocket, connect a transducer to it, and you have an imaging system. And so this is really life-changing for critically ill patients to try to do a very quick examination to see if there's bleeding, internal bleeding, for example. In natural disasters, it's being used more and more for public health. During COVID, there's a whole new field of lung ultrasound that has suddenly opened up because of COVID, where they were able to use ultrasound to look at the lung movements. And often people don't think that we should be looking at lungs with ultrasound because it's an air-filled structure, and air is usually terrible for ultrasound. But actually, they showed that this is a very useful diagnostic modality. Of course, it's used in the emergency room. We heard a lot about recently about space and space medicine. Ultrasound is, again, one of the only modalities that is available in space if you want to look at imaging. And so it has been used for many years in space medicine. It's becoming more and more popular, and the technology is improving. So this is ubiquitous. It really has been transformative. In our group, we have been actually thinking about the next paradigm shift. So how can we actually not only just have this handheld transducers, but can we actually truly make this wearable? So this has been over the last 5 years or so, it has again become a very hot topic in ultrasound. There are several groups that have published very high-profile papers in Nature and Science talking about these wearable ultrasound systems. So these are now patches, almost like Band-Aids that you can apply to the skin. And the technology has improved so much that you can actually do imaging with these patches. So instead of a Fitbit or any kind of wearable sensor, now you have the ability to do imaging with these kind of sensors. So this is something that, again, is another step forward. People have been trying to develop, so a lot of this has been driven by the material science innovation, so trying to have this very flexible copolymer-based transducer arrays that can be then connected to electronics. In our group, we have also been one of the pioneers in looking at a different way of doing wearable ultrasound. But that's this is a potentially could be another paradigm shift in how imaging can be more ubiquitously used, and not just in a clinical setting, but also in settings where ultrasound usually has never been used. So we recently published a paper that talked about the sort of the where this might be going, and there are many applications which are fairly traditional, like cardiovascular rehabilitation and so forth, where ultrasound is being used right now. But we see that wearable ultrasound can actually be used for these kind of applications, but in completely different settings. So imagine a runner wanting to know their cardiac function while they're running a marathon. That's a cardiovascular imaging problem, but now it's in a completely different setting. It's not a hospital-based, clinical-based setting, but we can, the technology is there to be able to do something. We are working a lot in rehabilitation. We are working with athletes who are recovering from an ACL injury. And so while they're doing these jumps during their regular training, we have these sensors put on their muscles, and we are looking at the muscles in real time as they're doing these highly dynamic jumps. And so we can get more information about what might be happening at the level of the muscle as they're recovering from an injury. So there's also many other applications in sports sciences and fetal health. Military medicine is another big application where we're really trying to take the operator dependence away from the imaging aspect of it. So in military medicine and space medicine, the person who's going to be using this device is not a trained sonographer. They are, they're just regular soldiers or other operational people who are now being called to collect data on somebody who is injured. So we need to not rely on the expertise of the sonographer to collect the right information. So how do we use AI? How do we utilize the sensor technology to overcome some of these things? So these are the things that we think are coming down the pipeline. So I'm going to skip on some of these more technical things. So this is the landscape of where wearable ultrasound is being used right now in research settings. So people have been using these arrays that are patches. This is a group out of UC San Diego who's been doing really amazing work on this. People are building these multi-element patches. So these are not just array transducers, but groups of patches that can do essentially one line of imaging over time. There's a company called Flowsonics that's developing this vascular imaging device. So they're using that for monitoring sepsis. And the way to think about this is we are not doing imaging anymore. We are really thinking of ultrasound as a biosignal. So it's a time-varying signal now that we are monitoring as opposed to a snapshot image that we're using for diagnosis. So the use case is completely different. And so the example biosignals that are being used are blood flow velocity. That's one the signal that we can extract. We can look at cardiac contraction. So this is called M-mode imaging. So essentially one line of ultrasound over time. And you can look at the valve motion, for example, or the heart wall motion, and try to extract some useful information from that. In our group, we have been doing a lot of work on using similar ideas, but for looking at muscle contraction. So looking at the deformation of muscle over time. And so again, think of this as a biosignal analysis problem rather than an imaging, diagnostic imaging problem. And so there are many applications. The ones that I'm going to talk about briefly is prosthetic control and monitoring muscle function. So we are talking about a completely different way of using ultrasound. And so in our group, we talk a lot about this human-centered design. How do you actually figure out what the technology should look like? Now it's a completely new use case. How much should we design? Should we design a full-fledged array with 128 elements, with full beamforming, with all these sophisticated things that looks like a traditional ultrasound system? Or should we completely reimagine what an ultrasound might be in this new application? So that's where we do a lot of work on really understanding the use cases. So we go out and talk to people who might be using it, do a lot of qualitative methods research, which is hard for engineers to get used to it. But we are doing true qualitative methods research. We are actually looking at different use cases. We are doing a lot of customer discovery. So we have these NSF iCore projects where we talk to 150 different partners to try to better understand what these use cases look like. And then develop very minimally viable prototypes, not over designing the system, but really design a simple prototype that can solve the problem that we might be able to address, and then really iterate from there. So understand what the issues might be, and then try to come up with this. So this is, again, very different from traditional academic research. In traditional academic research, you, at least in my field, you develop something in a benchtop, you test it extensively, then you go to perhaps animal studies, you test it extensively, then you go to human studies, then you test it extensively, and then eventually you hope that somebody is going to commercialize it. So that paradigm, I'm arguing, is very inefficient, especially when we're talking about something that is potentially a new way. So this whole iterative, don't over design it, but test out a prototype first in a real actual setting and then come back and redesign it, is again difficult for grad students to deal with because it's highly iterative. So the design is not a linear process anymore. You don't have these nice 3 aims of your thesis anymore. So it's a challenge to pull this off in academic settings. We're trying to figure out how to do that better. Again, in the musculoskeletal applications for this, there are many areas. So sports science in general is moving more towards wearable devices. So we are thinking that adding imaging in some of these applications could lead to some improvement. So the projects that we are working on are prosthetics and exoskeletal control. We're also looking at musculoskeletal injury prevention. There are many other application areas that we're sort of scratching the surface on. We're not quite, we'll work through these over time. So this is an example of a very simple proof of concept wearable ultrasound system that we developed just to figure out what the use cases might be. So it's a single element transducer, nothing complicated. It doesn't do full imaging. It's just one line, single line. And we really realized that one of the biggest challenges is really the electronics. So you cannot really have this connected to a desktop or benchtop setting where it's doing full-scale imaging. So we came up with some creative ways to rethink what the signaling might be so that we can significantly miniaturize the electronics. So this is our current prototype. This is not optimized. This is made in the lab still, but once we commercialize this, this will be very, very small. So essentially it's an FM radio. So the way we are doing it. So it can be very, very simple with a single element transducer. And really the design considerations are form factor, the ability to transfer a minimal amount of data with very low power consumption and so forth. So I don't want to go through too much of the technical details, but if there is interest, I can come back to this slide and I can talk through some of the technical details of how we do this. But these are some of the use cases right now. Again, this is not an optimized system. We are trying to put an ultrasound system inside a prosthetic socket. And that's sort of where our vision is. And we are close to this. This is our initial prototype. The next generation will be much smaller. And then the other use cases, we have these sensors on different muscles as people are doing rehabilitation exercises, and we're trying to do more precision rehabilitation. So we talked a lot about, the sort of the whole person health really is not about technology. And this is something that we truly care about. And we are developing technology, but we really need to understand where the technology is going to be used and in what use case. So we are doing a lot of work on prosthetics. I know there's a lot going on in this institute as well. But we really need to think about the continuum of care for prosthetics. So where individuals get clinical care, what happens after they go back into the community? what kind of care is available to them. Many of the subjects that we work with almost never use their prosthetic for doing activities of daily living. They're able to do it without using a prosthetic. Even if they do use a prosthetic, sometimes it's not these sophisticated multi-articulated hands. So really trying to understand where does technology fit into this, into somebody's life, and what can it actually enable them to do that they could not do before. So really understanding that is one of the things that we're still trying to get better at. So the traditional way of thinking about this is using the ICF model, where we talk about the loss of body function structure, which is essentially, say, the loss of a limb. So we're trying to replace that lost function. But that does not automatically translate to participation, which is where the goal of rehabilitation is. Can you have these individuals participate in life activities that they could not before? So where does the technology fit into that goal of participation? So that's something that is a very complex problem. That's the frameworks that I talked about. That's where it all fits in. But nevertheless, the technology is still important. But I would argue that there is a gap between how engineers think of this problem and how prosthetic users think of the technology. So it turns out that we have made major progress in sort of the design of these kind of devices. This video. So the very sophisticated electrode pattern recognition systems that are commercialized right now, they cost a lot of money, but they are, in real life, they are very difficult to use. So many of our users tell us that they actually hate their $40,000 hand that they spent many years trying to get insurance to pay for, because it just doesn't do what they would like to do. So technologically, it's an amazing device. It is, it has multiple degrees of freedom. It has all these sensors and sophisticated algorithms for pattern recognition, but functionally, it's still not helping them in their daily lives. In fact, many of them still prefer a body part prosthesis, which is Civil War era technology. It's a harness with a hook, and they like it because it's reliable, it doesn't break, it doesn't require batteries, and they know exactly what it does. So they have full agency over the use of that device. Whereas with these very sophisticated electronics powered hands, they don't always know what the hand is going to do. There's this gap in agency. They try to do a muscle contraction, but the hand doesn't quite do what they're asking it to. So that breakdown in agency is a big challenge that we need to try to address. So people have been trying to work on this for many years. More recently, there's been a lot of really exciting work, for example, in this group, on implanted devices, which can really take this to the next level with restoring sensation in addition to the control. So that's really one of the frontiers. We are trying to address a much simpler problem, hopefully, which is that the electromyography, which is the sort of the traditional way of looking at muscle activity, is still 70-year-old technology. It's not really, and the EMG has not really advanced as much over the last 70 years. And what we're trying to see is, can we come up with better, at least the signals from the signal side, can we do better than EMG? It doesn't solve everything, but hopefully it's a little bit of an improvement. So our value proposition is, for those who do not want to get an implanted electrode, can we come up with a better non-invasive solution than just straight EMG? So that's what we have been working on. So we did this work has a sort of culmination of almost a decade of work in our group. We started with a traditional imaging ultrasound system, and the advantage is that with ultrasound, you have this depth resolution that with EMG you do not. So now you have the spatially mapped activation patterns of muscles, and that gives you a lot more data to work with to get more robust control. So we are able to do grasp classification. We can put them inside a socket, and we can look at this over time. And really the advantage, again, is that you have this additional dimension of depth. So we have shown in studies that this actually seems to do quite well. So we have very good precision and proportional control. So here's on the left, there's a subject who was chatting with our grad students in the lab, and there's an ultrasound imaging probe inside that socket, and he's using that control to modulate the amount of force he's applying in the water bottle so that the water doesn't spill. And he's able to lift that up, and he's looking away and still able to maintain that control, which is really what we have been trying to get to for a while. The big challenge with all this is, ultrasound is actually very sensitive to motion. So if you're working in a large workspace, will this still work? And we have shown that it tends to do that, at least with an imaging probe. So this is one example of what the benefits might be. So this is the same subject who's a very experienced prosthesis user doing a box and blocks task. It's a fairly standard outcome measure. So with the bioelectric prosthesis on the left and our ultrasound-based method on the right, and we may see that they transfer the same number of blocks, but if you watch the individual on the left, they are using a lot of compensatory movements. So they're using their trunk and they're using their shoulders. That's because they are trying to compensate for the sort of loss of dexterity at the end effector. Whereas on the right, this individual is standing up straight. The same individual is standing up straighter with better posture. So hopefully there are other ways of evaluating than just looking at how many blocks can you transfer, which might actually have some relevance to clinical outcomes. So we have been trying to get towards a commercial product with this. So we have this now wearable sensors that we have shown that can get proportional control as well. And again, I'm happy to go over technical details later if there's interest. So right now we have two clinical studies going on, one at Walter Reed with some of the same collaborators that you guys work with, and another one at National Rehab Hospital. And so we are now putting these ultrasound sensors inside a socket. That itself is a huge challenge. So what is the design constraint here? How should we put these sensors? Should they be attached to the hard shell? Should there be a band that you put the socket on top of it? So there are many iterative design decisions that need to be made. And the challenges are sensor shift. This kind of ultrasound is very sensitive to continued skin contact, so we need to make sure that we are able to do that. During dynamic movement, the signal quality can deteriorate. Each individual has a unique musculature, so you cannot really rely on a lot of this kind of transfer learning of machine learning models. So these are all problems we are working through, but this is right now in clinical trials. Let's see. How am I doing in time? Okay. So one of the things that we, and this is something that a lot of the work on sensory integration is really focused on, is that our dexterity is not just about better control of the motor system. It's about really integrating sensory information as much as possible into the loop. In fact, some have argued that the sensory apparatus is so much more complex because we rely much more on sensory input than on this kind of different motor input. So when we're doing a task with a prosthetic, there's many different sensory cues that individuals are currently using. They are using visual feedback, they're using auditory feedback, they're listening to the motors, they're feeling the vibration of the motors. So they're already relying on a lot of sensory cues already. But there are still gaps. Of course, there's no haptic feedback, which Ranu and Jimmy are trying to solve with the implanted neurostimulation. But there are other things like proprioception, which is also important. So one of the things that we have argued is that with ultrasound, since we are relying on the deformation of the muscle as a source of the control signal, that our control signal is more in line with the proprioceptive sensory effort. So this is something that we wanted to test. So this is one of my grad students tried to see, if you remove visual feedback, if you remove other types of feedback, can you rely purely on proprioceptive feedback from the ultrasound and the feeling of where your limb is in space or where your muscles are to get to a target? And what we found is that the visual feedback is very important. If you add proprioception and haptic feedback, you can actually almost compensate for visual feedback. So the performance that you get with if you're doing a target control task, where you present a target and you're trying to get to that target reliably, a lot of the times people will rely on a visual feedback of where the target is. But if you use proprioception and a vibrotactile feedback, you can actually replicate that. The other interesting thing is that what we have discovered is that there is a lot of intrinsic motor control information that we're getting from these ultrasound signals. So we have shown recently that the limb trajectory follows this minimum jerk trajectory. So there is a standard acceleration. Then once you reach the target, there's a deceleration and control. That actually is replicated even at the individual muscle level. So if you look at the individual muscle velocity trajectories, they follow very similar trajectories as the limb. So this gives us some opportunity to really study more of the motor system itself from a more basic science perspective, to really better understand what might be happening at the level of motor control. This is not something that you can do with EMG, because EMG is giving you electrical activation, not the mechanical the deformation. We have also been looking at other applications. So this is a study with individuals with spinal cord injury. We showed that they also are able to do this target control task, even with the incomplete spinal cord injury, and with very similar dynamics. That was interesting to us, is that the velocity profile of the individuals with spinal cord injury looked very similar to the velocity profile of individuals who not have injury. So in the last few minutes, I'm going to briefly talk about musculoskeletal injury. And this is, again, a huge problem. In athletics, of course, nearly 75% of athletes will eventually have some kind of a musculoskeletal injury. In the military, this is a huge problem as well. In the general population as well. So in athletics, there was a recent case of Juju Watson who had an ACL injury. So recovery after these big injuries is a very complex process. It's a very individualized process. Not everybody will recover at the same rate. There are many other confounding factors that might influence the recovery from injury. So really, how do we get more data on the actual recovery process? So right now, the standard ways are looking at essentially relying on the judgment of the clinician to understand muscle strength, asymmetries, and so forth. And at some point, there's a decision on, is this person ready to go back to play? And there's been data that show that if that decision is not made correctly, if people do not follow this proper rehabilitation, the re-injury rate can be as high as 70%. So, and once you have a re-injury of an ACL, then the rehabilitation is even more complicated. It could actually be career altering in some of these athletes. And this is true for the general population as well. So it is very important to get that rehabilitation process right, and really have better metrics to guide that rehabilitation process. Because right now, again, we do not have data on individual muscles and how they're contributing to, for example, stabilize the knee joint. We know we can get metrics like, on a force plate, we can get jump metrics, we can get ground reaction force, we can get joint kinematics from motion capture, but we really do not know what the relative contribution of the vastus lateralis and the vastus medialis are on stabilizing the knee joint, for example, during the. So this is where we think that ultrasound can provide some added information. So we are, this is an example of our system right now. Big cable is really for connect data collection at this point. I mean, the cable is not necessary for anything else, but we're trying to capture as much data as possible. So this is one of the athletes in our volleyball program. She is doing this counter movement jump. And she has these 4 sensors on the quadriceps muscles bilaterally. And this is something that we can do with our system that you cannot do with traditional ultrasound, because with the traditional ultrasound, you're limited to a single transducer that can only look at a certain region of interest. But with this kind of wearable system, now you are no longer tied to a particular anatomic location. You can put these sensors on many different muscles bilaterally. You can look at the tendons, for example, as well as the muscles at the same time. And so we are able to get this kind of deformation metrics. So muscle, as the muscle is contracting, it changes in shape, and we are essentially capturing that shape change. And we're trying to relate that to how the individuals are recovering. It's a complicated measure, and again, trying to make sense of how muscles contribute to joint stabilization is not straightforward. So again, and your fatigue level makes a difference. How much you slept last night makes a difference. So there's a lot of kind of complex systems, things that we have to look at. So how do you integrate all this information into something that will give you a measure? So this is some ongoing work. So with that, I'm just going to summarize that what we are trying to extract really at the end of the day is, can we extract individual muscle force? That's been one of the sort of the holy grail of biomechanics, and we are trying to do that by looking at muscle shortening velocity, cross-sectional area, and so forth of individual muscles. There are different imaging ways of doing it. We can look at single element systems. We can do a Doppler. The advantage of wearable is really you're no longer looking at static images, but looking at this as a biosignal over time during dynamic activity. It's very difficult to do with regular ultrasound. But there are many challenges that still we need to overcome. How do we validate these biomarkers? How do we get truly actionable information from these biomarkers? This is something that we are still working on. There are some engineering and technical challenges. How do we get robust data coupling, transducer coupling to the skin, and so forth. So this is all ongoing work. So I just want to acknowledge our group. So we have a very dynamic group of students and postdocs and research engineers. So we have about 25 people in our group right now. Many of them contributed to all the work that you saw today. We have a number of collaborators both within Mason in our center as well as at other universities and also in industry. And so I want to acknowledge our funding and thank you all for your attention.
Let's start with a question from online. This is from Gustav Ganguly from Karolinska Institute in Sweden. He says, fantastic work and heartiest congratulations on the integrative convergent solution driven research. And this is a two-part question, so I'll read the first part. He's particularly interested about the lung ultrasound and if you foresee the wearable US can be used for non-acute lung diseases when lung is not fluid filled as in COVID, as well as in remote low resource settings. And the second part of that question is if you'd be able to talk a little bit more about the NSF training program and how your team motivates students to enroll in high numbers and the cost or if it's free.
Yeah, thank you. So those are excellent questions. So the lung ultrasound is a really.
Can you repeat the question?
Oh, sorry.
So
yeah, so there were two questions. One was about the use of point of care ultrasound, and especially wearable ultrasound for lung imaging in non-acute lung disease, especially in low resource settings. And the second question was about the NSF training program, how we recruit and so forth. So the lung ultrasound question. So this is a hot topic now. There are actually conferences on lung ultrasound. This has become really a big topic. So there's a lot of ongoing work. I think yes, there's. So traditionally, it was thought that there are some standard acoustic features that you can extract from imaging that are significant. So there are these A lines and B lines and C lines that we talked about, and so though all of that potentially can also be done with wearables, it is not technologically it is feasible. I don't think anybody has done that yet. But certainly something that can be done, especially in low resource settings that would be really interesting. One of the big challenges is again standardizing the acquisition. So that's a lot of the work during COVID was trying to figure out where to image, how to image, especially for somebody who's not a trained sonographer. So combining this kind of AI-driven guidance with this kind of sensory could potentially be helpful. And for the training program, yes, that was actually. This is, we have a large university, and so we have a lot of students. But we, for the first year, it was actually, challenging to recruit because students didn't know what to expect. They didn't. This was a crazy program that's very different from what they are doing in their dissertations. The advisors didn't know what to expect. They didn't know whether this would be beneficial for the students or not. But after we got through our first cohort, then sort of the word of mouth spread, and that really helped us. So our students who were trainees became our biggest ambassadors. So they really helped many other students, and we're the NSF training program is interesting because it's unlike an NIH training program, it's not renewable. So we're not eligible for renewing it, but we can apply for a new one. But we are also expected to continue the program and somehow institutionalize it. So that's what we are doing right now, is figuring out how to institutionalize the program without the NSF support.
Questions?
Do you see in the wearable ultrasound area, do you see it being utilized for pregnancy as well? I saw you said fetal medicine. So are they doing like being able to track both the mother's health and the fetus's health, or maybe just the fetus during pregnancy? Where is?
Yeah, we have had some interesting conversations about that. So yes, I think potentially we can. We just have to find a good use case where this might be helpful. There is also a lot of point of care ultrasound is being used for maternal medicine and low risk settings. So there's a lot of ongoing work on guiding a non-expert to get images that could be diagnostic. And so there's a lot of ongoing work already. Does wearable ultrasound fit into that picture? We still have to see, but there might be some use cases where it might. So we were having an interesting conversation with Alejandro yesterday about this. So yeah, so there might be opportunities.
Oh, hold on. Meredith, Jimmy, then Justin. Okay.
On the point of care ultrasound, you mentioned it's very advanced. You can do it in low resource settings. You can hook it up to a smartphone. But recently there was a call from international. Sorry, I have brain.
Okay.
The global one about the point of care ultrasound. Oh, what organization was that from?
Don't remember, but
Nobody remembers. Anyway, they made the point that point of care ultrasound needs more advancements, particularly like AI to read. And I was just curious your thoughts, because I don't think you talked yet about like what advancements were needed.
Yes, and this is again ongoing work right now. A lot of people in the field are working on this. So you're absolutely right. So the question was about what other advancements are needed to point of care ultrasound, because before it becomes widely used in low resource settings. So right now, there's still the bottleneck is, point of care ultrasound as it's used right now is still operator dependent. So it's very dependent on how much pressure you're applying with the probe, what orientation of the probe is. Do you know what a good image looks like? Do you know what anatomy you're looking at? Especially if you're not a highly trained sonographer, those can be very challenging. So, people have been talking about this kind of telemedicine guided use, where that was what was being used a few years ago. Is there would be a trained professional, let's say, in a remote location somewhere in the US or Europe or wherever, and they're over the phone, or over an internet connection, they're explaining what, or providing guidance on what a good image might be. Increasingly, with AI, you might be able to do that much more rapidly. You don't really need this telemedicine. So an AI can recognize what a good image might look like, or it can, if it's not a good image, it can tell you what to do next to get that good image. So that is getting better and better, and actually many commercial systems have started to apply this kind of workflow applications for AI. I think it is still the use case is a individual holding a transducer and trying to gather images. What we are arguing with wearable is that you do not need to hold the transducer anymore potentially. You can just apply a flexible patch and push a button, and hopefully the AI will help you collect a good quality image. So that's sort of the use case we are envisioning, but still lots of work to be done.
Okay, great. And it was Bill and Melinda Gates Foundation.
Yes.
I also wanted to ask about the wearable ones, and I think you just answered part of it, but when you say that you've got this array patch that you're putting on, so are you somehow, is it because of the way you're doing the sensing that you're avoiding the need to put the pressure, or is it really application dependent where it's applications that don't require that?
Yeah, that's a great question. So the question is about, how much pressure do we need with these patches, and how critical is that? That's actually something that we are dealing with even in our application right now. Is you cannot just have almost no pressure. You just apply like a Band-Aid and it works. You do need some kind of a constraint to be able to get good coupling, and some of it is potentially because of the subcutaneous fat cells in the subcutaneous tissue, and so you basically need some pressure to be able to get them out of the way to get a good quality image. It is still an open question. Do you need a diagnostic quality image, or do you need actionable information? So I think if the goal is to get an image that's as good as a traditional clinical ultrasound, I don't think you'll get there very soon. That requires a lot more work. But if the goal is to get actionable information from a somewhat lower quality image, then you might be able to.
And so when you're doing that with the prosthetic application, and even what some of the other applications you talked about with the wearables, how long can someone be wearing that and use it? Are you using gel, and does
that's another. So the question is about gel for coupling and so forth. So we actually do not need to use this kind of liquid gel. There are more other materials that you can use. So we're looking at elastomer and so forth, hydrogel based things that can be much longer lasting. So there are opportunities to do that. If you do the matching correctly, you may actually not need to use gel. Just a natural sweat might be enough of a coupling medium. If you innovate on the matching materials and the kind of transducer material that we use for the piezoelectric. So for example, a PVDF is one material that we are using that is much closer in acoustic impedance to tissue. So it doesn't require it doesn't require a lot of gels. So there are ways to overcome that. How long can you use it? There are two parts to that question. One is, what is the safety? We know how safe it is. Ultrasound is known to be safe if it is used properly. So if you follow as low as reasonably achievable guidelines, and there are standard guidelines from the American Institute of Ultrasound Medicine and the World Federation, where they tell you how long can you use at a certain acoustic output level and so forth. So it has not been used kind of this chronic long-term use case before. So right now we are doing an animal study to better understand are there any bioeffects associated with very long exposure. So wearing it every day for 30 days, would that make a difference? We don't think so, but it's still an open question that needs to be answered.
Just
So my question already got answered. I do have another one. So for the training grant, right? Were there any projects that have stood out to you in particular?
Yeah, so there's one project that I'm particularly proud of. It's like a student group that, a lot of these students, as I mentioned, we have a very non-traditional student body. So many of the students actually have lived experience of the problems that they're interested in addressing. So we had this one group of students who wanted to work on substance use disorders because they themselves had family members with that. So they wanted to work with a community partner, Chris Atwood Foundation, and they have these peer recovery specialists in the field who work with other individuals in recovery. And they basically try to connect them to services and make sure that they're following up on their appointments and so forth. And these peer recovery specialists, they have this booklet of resources, and they go around, and they often have to make phone calls to figure out if some clinic is taking appointments, if they're taking their insurance, if that shelter still has availability. And this is basically a lot of work of the peer recovery specialists to really manually navigate the whole system. And the system is very fragmented, it's very complex. There are many different social support systems available, but they don't talk to each other. And so this team developed an app that hopefully can have real-time updates of what's available and really prevent somebody having to look up something in a booklet, make a phone call, and hopefully the app will give them more real-time information. So that project that app is being used right now. So there are many the recovery specialists that are using it right now in the Northern Virginia area. These guys formed a profit company that's trying to sustain it, looking for funding and so forth. So this is one of the projects that came out of this. Not a traditional research project, but something that actually is making.
Indeed, you answered all my question as well, but I have a short comments. American Gynecological Association does not recommend outside of clinic ultrasound and does not recommend frequent ultrasound.
That's right.
So that's a huge obstacle for.
That is absolutely right, and that is because of the it is ultrasound does have bioeffects. So if you increase the acoustic output and you expose for very long periods of time, you will cause potential bioeffects because there is heat. Potentially, there's mechanical energy. So yes, traditional ultrasound with acoustic parameters that are used for diagnostic, you should not be using it at home for long term. But if you can modulate the parameters down so that you are not requiring diagnostic quality imaging, potentially there might be use cases. So for example, fetal heart rate monitors are often used for long periods of time, and that many of them use Doppler ultrasound techniques. So there are ways of there are safe use cases, but not the traditional imaging systems. Yeah.
I just wanted to mention that I do feel like that's a barrier that should be overcome because when I had a really bad horse riding fall during my pregnancy, immediately after the fall, I did a CT for because I had a concussion, and they did do an ultrasound then. But when I went into the doctor the next week and I wanted her to do another ultrasound to make sure the baby was still okay, she was like, well, I can't do that because the ultrasound tech isn't booked and it will cost a bunch of money. And so let me use my handheld Doppler. Let's check the heart rate. And if the heart rate's okay, probably the baby's okay. But like it just seemed crazy that she couldn't do an ultrasound right there and just like check and make sure everything was okay. And if it was more accessible even in the US, it's like that would be good.
Yeah. And there are companies that are working on sort of working to address some of these concerns. But yeah, you're absolutely right. There are safety considerations that we have to make sure that we are not causing unexpected harm.
Okay, one. So
Let me just want to say, the Zoom people, we are at time, but we can continue to ask questions, but at 10 o'clock this time, but we have availability.
Yeah.
So.
my question has to do, you talked about these fancy, technologically advanced arms, and a lot of users end up hating. What I'm curious about is, does that tend to be age dependent, meaning the older they are, the less they like the technology, or is it pretty even across the board?
I have not seen a systematic study that looked at that. There might be, but just based on our anecdotal experience, I don't think there's a relationship with technology acceptance. So it's not technophobia that's driving this. It's really about whether this is functional in individuals' life. So many of our participants are not in their 30s and 40s. They often do not use a prosthetic. They're able to, especially individuals who are born with limb difference, they are very functional in their activities of daily living without a prosthetic. So it is, but that does not mean that they do not need a prosthetic, right? So there are some things that they are not able to do where they could benefit from using functional prosthetic. So again, trying to understand what that specific use case is and trying to design a system that will address that problem.
Yeah.
Kind of the same topic area. Mostly on the topic of using ultrasound for prosthetic control. A lot of people who use these prosthetic devices sweat a lot under the socket. How does sweat affect your ultrasound signals?
It's actually a huge benefit for us because sweat is a coupling medium, water-based. So that's one of the reasons why the answer to this question about coupling, we may not need an extra coupling gel because the sweat automatically is provides a comfort.
Do you have to worry about the socket, I guess, moving along the arms?
That's the bigger problem for us, is that, the socket motion and how do you overcome socket motion is probably the bigger challenge that's right. That does tend to happen, and especially if you're using prosthetic in the usable workspace, the forces are different, the tilts a little bit, and image quality is very sensitive to orientation and so forth. So we are trying to overcome some of those things. So there are ways to technologically overcome some of those challenges, but those are important challenges that we're working on.
Maybe any other questions?
I
Oh,
have
okay.
a question. Can you share anything about your work with MTech? Like how's that relationship and how's it been working with them?
Yeah, so this is my colleague Parag Chitnis, who has 2 MTech grants right now. So MTech is a membership-based consortium. Do you know what MTech?
Yeah, we are members, but I noticed it too and was going to ask you, how did it happen? Because no one has applied for the grants yet, so I'm trying to get people to apply.
Yeah, so I think you guys are really well suited for the kind of things that MTech is looking for. So we have, so the 2 projects that we have going on are really related to musculoskeletal injury prevention. So we had some introductions with some of the program directors there. We had several discussions with them, and so we were able to really address what they were looking for one of the projects. So that kind of personal outreach helped for us to better understand what they were looking for, and for them to also see what our capabilities are. And so we got the first one and then the second one as well. Again, focused on injury prevention and rehabilitation after injury.
The ultrasound base?
So that helped us build out a lot of our sort of fabrication capabilities and work with our athletics.
So I think we could learn a lot from you all, because we are members, but what it may need to be the personal connection or reaching out and actually actively participating in their calls. So that building that connectivity. So I'm going to take this as an opportunity to tell all the members here that you have this opportunity to. But I have one last question, perhaps, that all of the work you're doing with the community-based engagement and all of that part. And on the other side, there's this high-end technology. Have you some ideas, suggestions, or things like that of how might you introduce this into that? Because I get back to this, what you don't know,
Yeah,
right?
right.
So this is the hard part of, if you ask somebody what you want, it is up to their imagination
That's right.
of what they want, and they may or may not have that imagination of this technology.
That is absolutely correct. So I think we talk about this from both sides. So I don't think this is necessarily. We have parallel research going on. So one of my postdocs is really trying to better understand, that whole ICF model. What does an individual with limb loss, how do they define success in their activities of daily living? What do they define success in participation? And then really trying to figure out what is the role of technology in that. And if you ask them that question, they may not have the answer to that. They may not know what technology might help. It is also incumbent on researchers to really try to bridge that gap. So we have to, we cannot just be focusing on technology and just do this kind of focus group to understand what the needs are. We really have to bridge that gap and figure out what technology might actually address a need, and what might that look like. And so we are sort of in parallel developing the advancements in technology with the hope that it addresses some gap. It may not. It may just be that this is still science fiction for now. But at the same time, we really need to understand what the needs are, and there might be other ways of addressing those needs with existing technology or existing methods. So we can continue to make impact while working on technology advancement.